Director of Prenatal Genetics in our Fetal Medicine Institute. Jamie is also Director of the Myelin Disorders Program. She's a medical and biochemical geneticist of renown, and she's going to be giving us an overview today on everything to do with genes and genetics in prenatal medicine.
Okay. High expectations. In 30 minutes, give or take. So thank you. So our objectives today are to understand the contributions of people like me in the medical genetics community to complex fetal consultation, to identify reasons to refer to fetal genetics, and to become more familiar with complex genetic testing modalities that we use in complex cases and how they assist us in fetal evaluation, to both obtain diagnosis, help with decision-making, and plan future pregnancies. So what do we do? Medical geneticists work in concert with our amazing genetic counselor colleagues to create an environment that is focused on interdisciplinary and whole family care to allow us to provide unifying diagnoses when possible and reduce the Diagnostic Odyssey timeline for families. And we also attempt to coordinate very smooth transition to postnatal care as well. So what are we playing in all this role? So our interdisciplinary team here at Children's consists of radiologists, cardiologists, neurologists, nephrologists, endocrinologists, neonatologists. We have a lot of ologists. And as well as our wonderful surgeons and medical geneticists like myself and our genetic counseling colleagues. So we like to think of ourselves as one of those whole body people. So we take the information that we receive from our wonderful radiology colleagues and look at the findings of those babies as well as family history, and we unify that message along with our other subspecialist colleagues to try to give families an idea of the big picture for each pregnancy and how we can help answer questions any family might have. So in the setting of whole family care, what does that mean? We sit down with both mothers and fathers, sometimes their grandparents, their siblings, and we talk about things like, what is the findings that we see on imaging for the fetus tell us about likely outcomes? How does this affect decision-making for continuing or not continuing the pregnancy? Sometimes it's helpful because it can provide reassurance that parents who always hold worries that maybe they did something to cause a problem, we can reassure them that that's not their fault, that there are things in play that are out of their control, and that we're there to help with their emotional response and coping to these things. And we also help connect them with resources in the community that will help with that coping. And then additionally, we really focus on helping with family communication. So making sure that the members of the partnership that made the baby in question are talking to each other to help set goal planning and, again, working with decision making. We like to facilitate discussions with the extended family members as well. And then also with Child Life, we work on conversations with kids, other kids who are already in the family. As part of that, we also, again, reunify the message with all the other providers who meet with the families depending on the outcome and the findings of the pregnancy. So with respect to finding a unifying diagnosis and reducing Diagnostic Odyssey, one of my major focuses is on once we see a major anomaly, are there more? And so I feel really blessed here at Children's because I literally have a person who wrote the book on fetal imaging who is one of my partners in crime. And so we have great advanced ultrasound imaging, fetal MRI, and our wonderful fetal and pediatric radiologists and neuroradiologists on board to help us get to a diagnosis. And oftentimes these folks come to us after having had a karyotype or a microarray. And so once we have that information and we have our imaging, it helps us get to a point where we can talk about decision-making with the information we have and whether or not there's additional diagnostic testing we can do depending on the options the family are presented with. So going further with that, decision-making, delivery planning, and postnatal care are also focuses of our work. So once families receive sometimes very terrible news here in our clinic, we talk about whether or not they choose to continue a pregnancy or not, and if they choose not to, we talk about how we can assist with testing in the post-termination period. And during those times, we provide both pre- and post-test counseling for genetic testing and provide those results. If families choose to continue a pregnancy, we assist with delivery planning, whether that be for palliative care or transition for a higher level of care and management. We can recommend special studies that can be done at the outside hospital or with our NICU if they're transferred. And again, we do make those connections to palliative care, which are very important for many of our families. And then finally, in the postnatal world, many of our patients are delivered at local hospitals where there is some availability of genetics evaluation, be it at Inova Fairfax or at Holy Cross and sometimes Shady Grove with my colleagues who see at those outside sites. In addition, the on-call physician for the week in genetics will see babies in the CNMC NICU who are transferred for additional consultation and evaluation, and so we do that as well. And then for those babies who are stable enough to go home with mom or shortly thereafter at a local NICU or with the nursery, we follow them up pretty quickly after discharge within about a month or so, and that happens in the fetal medicine genetics clinic. So why would you refer a baby to fetal genetics? So the three main reasons are a known or suspected chromosomal anomaly, maternal or paternal genetic conditions, and other family history that would suggest a genetic diagnosis that may be at play, and if there are major congenital anomalies in the fetus. So to start with the basic ones, those known or suspected chromosomal anomalies are important to send to us so that we can talk with families for genetic counseling, and that should occur regardless of decision-making status. So if a family is choosing to terminate or to continue a pregnancy, they need to understand what that diagnosis means and what it means for recurrence and what it means for the potential outcomes for the pregnancy. We talk about potential outcomes in the setting of a spectrum of diagnosis, so not every patient or child is the same, and so I don't have a crystal ball and I can tell you what the mild end of a diagnosis looks like and what the severe end of a diagnosis looks like, but I can't tell for certain what each individual child is going to do until they're out in the world. And then we also can help interpret and explain multi-organ findings and the impact on the clinical care needs of those babies when they are delivered. So if one person's focusing on the kidney and another person's focusing on the heart, usually we and our neonatology colleagues kind of come together to unify all of that together under an umbrella of care. That helps us talk about recurrence risk. So many of our families are very worried about, could this happen again? What does this mean for future pregnancies? What does this mean for our existing children when they have children? And all of those questions sort of eat at families over time, and so one of the things that we really focus on is trying to give them as clear an information as we can about how often this is likely to happen again or what they may have to go through in the future. And then finally, we can provide connections with other families who are living with children who have these specific disorders to give families sort of a personal connection in the real world that isn't a medical doctor trying to explain things in clinical terms. And we find that that often really helps our families because they can relate to people who are like them and they can understand what it's like and what it changes in their lives when they have babies who have difficulties. So here's an example. In the clinic here, we've seen about a 32-year-old female at 22 weeks gestation who was followed by maternal-fetal medicine for increased nuchal thickness, nuchal translucency rather. She had an NIPT that revealed 46XY. Karyotype came back concerning for mosaic 45X, 46XY because there were some concerns about the genitals on anatomy scan. So at the MFM's office, the GC provided initial counseling of those results and gave a very comprehensive list of the findings in what some people call mosaic Turner or 45X, 46XY. And so the couple at that point was strongly considering terminating the pregnancy because the information that they had in the way they had processed it in that initial period was overwhelmingly negative in their processing of it and their understanding of it. And so they came to fetal medicine for additional information about the diagnosis. They met with a multidisciplinary team, including the genetic counselors, myself, Peds, GYN, and cardiology, who helped us with and provided us a normal fetal echocardiogram result. So at that point, we were able to discuss the spectrum of Turner syndrome outcomes and what the specific findings in this particular fetus suggested about the possibility of outcomes. At that point, the family realized that while the dire information they had received on the far end of the spectrum for Turner syndrome at their initial consultation was accurate for Turner syndrome, that there are many other women who have Turner syndrome who don't present in that same very severe way. And so they requested contact with other Turner syndrome families who were similar to theirs, and are reconsidering their decision-making based on that additional information. And so one of the things that we can do is sort of refocus the conversation on outcomes regarding what's happening in the specific fetus based on imaging that we have and what we know about the disorder, not just from the prenatal component, but also from taking care of families at all stages of life with one of these disorders. And so that tends to provide a lot more insight to our families and allows them to assist with their decision-making considerations. Another reason that we see patients a lot of the times is if there's a parental genetic condition or other family history. And so oftentimes we do genetic counseling for the family, and we identify those at-risk individuals. We help make sure that they already understand their diagnosis, and we obtain their genetic testing so that they are in control of that information and can better understand it. We make sure that the affected individual has current access to care, whoever that family member may be, and then we use that information with their genetic testing to contribute to their recurrence risk conversations regarding any pregnancy, but specifically if they're pregnant now, a conversation about the existing pregnancy. And at that point, using our fetal evaluation techniques with our radiology colleagues and available genetic testing, we can then go ahead and give better anticipatory guidance for potential outcomes, again, what the spectrum of that diagnosis in the individual child would look like, and then how that would impact clinical care. So an example from that is we had a 29-year-old female who was at 32 weeks gestation who had myotonic dystrophy. It was confirmed by PCR, which is a repeat expansion disorder, but we didn't have an exact size of her repeat. And initially she was followed by her MFM for polyhydramnios and fetal bradycardia with mild hydrops in a male fetus, and she had a healthy older son. She came to our Fetal Medicine Institute for additional evaluation with MRI and receive additional counseling, and when she met with genetic counseling, myself, and the NICU, we discussed the spectrum of outcomes, but specifically focused on the findings in her baby. We were worried that her repeat number had expanded, leading from classic myotonic dystrophy to congenital myotonic dystrophy. And so we discussed the risks to the fetus regarding that and what that might mean for delivery planning and outcome. At that time, she decided she wanted to continue the pregnancy because she was far along. I think they were hopeful that the baby would not have congenital myotonic dystrophy, but would just more likely have myotonic dystrophy like she did. And in fact, the baby was delivered a few weeks early and ended up in the local NICU at the delivery hospital for a while, and then came over here for further management and planning for care in our neuromuscular center. At this time, we're still awaiting that baby's repeat expansion numbers, but mom's were in the window in which she could expand greatly pretty quickly to over 1,000 repeats. And so we were worried that that baby was at risk, and therefore that puts all future pregnancies where that particular chromosome is inherited at risk for massive repeat expansion as well. So another example, this was a couple weeks ago, we had a 30-year-old female at 20 weeks gestation whose partner had known myotonia congenita and had a lifelong history of laryngospasm, easy fatigability, decreased muscle strength with increased bulk. The couple's first daughter also had muscle stiffness, stridor, laryngospasm, and cyanosis after birth. Father had confirmed SCN4A mutation, and the daughter was found on workup to have an SCN4A mutation and a chloride channel CLCN1 mutation, which may be contributing to her more severe phenotype. So she had initially been, the older daughter had been followed by neuromuscular who had assisted with the testing, and they came to MFM genetic counseling initially for discussion, and then came to us for further discussion and counseling. Met with myself and the genetic counselors, and we discussed the fact that because there are two genes that play in this particular scenario, and we couldn't say for sure whether mom was carrying or not, there was a possibility that inheriting those two genes together may make the condition worse. And so we recommended the maternal testing that had already been ordered for mom to check for her carrier status for the chloride channel. And she agreed to do that the same day, so we helped her with that. And it turns out she carried the chloride channel, and so the older daughter, who had the more severe phenotype, had a bigenic inheritance of 2 genes that are probably working together to make a more severe presentation. The fetus was tested and has the SCN4A, but not the chloride channel anomaly, and so would probably likely more reflect the father's phenotype. That being said, that affects delivery planning because the family wants to be closer to children's and have our neuromuscular team involved, because there are medications that can ameliorate some of the more frightening aspects of the phenotype. Because the baby looks like they try to die, you know, with a couple of months of life, and it scares people pretty quickly. So we think that that'll help them a lot. They seem very positive with the plans that they would come back to have that discussion and then have delivery planning in the future. Okay. So the last one is very near and dear to my heart. Big thing, if you have anomalies in, major congenital anomalies in the fetus, whether it's congenital heart disease, skeletal malformations, brain findings, GU and renal anomalies and abdominal wall defects, or anything else that you're worried about, one major anomaly warrants careful evaluation for more anomalies, particularly in the fetal scenario, because we are limited in what we can do and we're limited in the windows for decision making. And so if one is found, additional images should be undertaken to try to get the best phenotyping available based on current technology. And so we recommend strongly that those kiddos with any of those defects get full evaluation in our Fetal Medicine Institute. And that would include a genetics consultation if those classical findings or other anomalies are identified. And just as a reminder to our colleagues who are not in the children's system, just because you're referred for fetal echo at children's does not mean that's an automatic Fetal Medicine Institute referral or fetal genetics referral. And so because we have separate scheduling and separate systems for referral, it's important to identify in the MFM community the need for perhaps double consultation with not only fetal cardiology but also fetal genetics or other individuals in the Fetal Medicine Institute. Further, our fetal genetics consultations are scheduled for cases with a high likelihood of genetic diagnosis, family history, or other known disorders. If the fetal evaluation suggests a genetic disorder, then geneticist, usually me, is on call and is available for same-day consults. If the fetal echo demonstrates congenital heart disease findings, again, we strongly recommend a referral to the Fetal Medicine Institute and fetal genetics for additional imaging and evaluation with more guidance and genetic counseling involved. An example for us on that score, so we have a 33-year-old female at 19 weeks gestation, was seen by fetal cardiology for evaluation, concern for a small heart. Echo here revealed hypoplastic left heart with mitral valve and aortic valve atresia. Baby was followed again at 24, 29, and 33 weeks gestational age and was delivered by cesarean section for non-reassuring fetal status at 38 weeks gestation after preterm labor. Was transferred to the Children's National CICU Cardiac Intensive Care Unit at delivery. The father of the baby reported a normal karyotype, but at the time the baby was noted to have a webbed neck, extensive redundant skin throughout the body suggesting a prior hydrops, dysmorphic facial features, and x-rays at stabilization revealed spinal anomalies. At admission, the baby had genetics consulted, and at that point the differential diagnosis was extensive because we didn't have any records for that baby in our system. And so a recommendation was made for microarray and a genetic sequencing panel to be determined sort of upon autopsy, because the baby expired the next day. And since family consented for autopsy, we're hoping we'll have a little bit more information for that family. But we're limited in our time frame for sequencing panels based on the timeline of death. One more of those. So we had a 37-year-old female at 20 weeks gestation who was followed by their MFM since 12 weeks gestation for abnormal first trimester screen with a noted thickened nuchal translucency and septated lymphedema. A CVS was performed and a karyotype and microarray were done. The karyotype showed 46XX normal female. The microarray showed a normal chromosome dosage, meaning there were no deletions or duplications, but there were extensive regions of homozygosity, and the family was of an ethnicity where consanguinity was expected, and they were known to be first cousins. Early anatomy ultrasounds showed a cystic hygroma, short long bones, narrow chest, and club feet, and the baby was eventually made it to us at the Fetal Medicine Institute for further evaluation. At the fetal MRI and ultrasound, the baby was again, 20-odd weeks, was 15 weeks and 6 days by size. There was severe micromelia with non-ossification at the fibula bilaterally and lumbar vertebra. Brachiocephaly was noted, there was a cystic hygroma, and there was a shortened undercoiled umbilical cord. Brain findings were also noted, which were important for cerebral hypoplasia and delayed development, probable corpus callosal hypogenesis dysgenesis, diencephalic mesencephalic junction dysplasia, and abnormalities of the brainstem, and possible pontomedullary dysplasia. That is in combination with some skull bone malformations that were consistent with the skeletal dysplasia that was seen on ultrasound. And then abnormalities of the developing inner ear were also noted. So we felt like the skeletal findings, in lots of conversation with Dr. Pulis and other of our colleagues, the skeletal findings were most consistent with achondrogenesis type 1B, but the brain findings were not. And so the question was, is this an alternative syndrome that could combine the brain findings and the skeletal findings? Are these two separate autosomal recessive disorders? We really couldn't know based on all of that information. And so we could figure, based on the exam findings on the baby, that skeletal dysplasia was likely to be perinatal lethal. And so there was some cultural issues around whether or not pregnancy continuation was in their plans, and so the family was going to review their options with their religious advisors, and we were waiting to hear back about that, but we'd recommended whole exome because the list of genes was so long at that point that we needed to sort of be very aggressive with figuring out where the risk factors were for both of these disorders, if there were two separate ones. So with that in mind, we need to talk a little bit about genetic testing modalities, so when I throw words out, people know what they mean. And the role that those play in fetal evaluation. So the scale of genomic variation is great, right? We can go see anything from whole chromosomes missing or extra to small pieces of chromosomes missing or extra, and even changes in the sequence with just a single misspelling that can create major changes in the outcome of a fetus in a pregnancy. And so at the cellular level in cytogenetics, we look at karyotypes for, oh, I just broke it. There we go. Okay, sensitive mouse. So we look at the chromosomes here, and those can be evaluated by counting. Very good cytogeneticists who have good, well-growing amniocytes can get better spreads, so they can see maybe smaller pieces missing or extra. But the resolution is down to about 3 megabases, which is not particularly helpful when you're looking for small pieces that may be missing or extra. Historically, people also used FISH for looking at larger deletions or duplications, and that is just a fluorescent probe that binds to existing chromosomes, and they light up. That resolution is a little bit better. It goes down to 200 kilobases, or 200,000 base pairs. It gives a little bit better objectivity. Really, in the prenatal world, we use it a lot for early response for aneuploidy screening, so looking to see if we have, say, 21 chromosome 21 times 3, or a missing X, we can use a FISH, and you have the turnaround time in a few days, whereas the chromosomes can take up to 2 weeks, depending on how poorly they grow. So those are the cellular level cytogenetic type testing that we do pretty commonly. The next level testing is the microarray, which lots of people use, and it's important to understand how that works. So there are two arrays that are in common use now, the comparative genomic hybridization array, or ACGH, and the single nucleotide polymorphism, or SNP-based array. They basically are looking for dosage change, and in the case of the SNP array, they can also tell us about things like consanguinity, if we have identity by descent, as we call it, or if you have inheritance of the same chromosome from 2 chromosomes from the same parent. So like both, the father contributes both chromosome 8 and the mother doesn't contribute 1. We can see that by these SNP arrays. So it looks at the whole genome and looks at it in small chunks with good resolution down to about 100 base pairs, and it's highly objective and it's measurable. So that helps us look to really quantify how big a deletion is or a duplication is, and if it is disrupting genetic function. And so just to give you an idea, at the detection rate for a karyotype on children with multiple congenital anomalies or intellectual disability, we can get up to about 5%, and that is usually based on aneuploidy alone or very large deletions and duplications. And then we go to the FISH testing, which is not used as much anymore except for aneuploidy. We can get about an additional 3%. With the use of arrays, we add on an extra 15% on top of that. And again, it depends on the size and the distance between the probes, but we get a lot better resolution of what's going on at the chromosome level when we use the array. And so for now, most of the time, unless you're just suspecting aneuploidy, that array is your best bet for outcomes quicker. So the genomic arrays, as I've said, the advantages are to detect and identify the exact location of small deletions or duplications. They are quantifiable and objective, and it can evaluate thousands of regions through the genome concurrently. It helps us define new syndromes and determine what the critical regions for disorders actually is. And it doesn't require living cells. So when you have products of conception, it's oftentimes easier and cleaner to get a microarray than it is to try to grow out karyotype cells for karyotype when that doesn't work. And frequently we can actually get tissue and archival samples to provide information about genetic balance even when the tissue is not available for live cell growth. The limitations for this study is we cannot see balanced chromosome rearrangements. So if there are pieces stuck together on chromosomes that are not in the right place, we can't tell that. It can't pick up the spelling mistakes or point mutations in DNA, and it doesn't detect gains or losses in it can only detect gains or losses where the area is covered in the array, which is usually pretty excellent by now. We've got excellent coverage throughout the array at this point. So this is very complicated. I don't want to overwhelm anybody, but basically the array CGH works with a combination of applying probes to the patient DNA and to control DNA, mixing them together, putting them on a flow cell type chip, allowing them to stick to the chip, and then if you have equal hybridization, it's like a 1-to-1 balance, then you have a normal dosage or a normal amount of a specific area of the chromosome. If the DNA is missing or there's extra, you can see because there's a difference in the amount of patient DNA per control DNA, and it'll identify a loss. Okay. And so this is an example where an array has detected a deletion on the 7q, where the patient DNA is here and the control DNA is here, and it shows the gap saying that there's more control DNA on the array than patient, indicating the patient has a shortage of that amount. And so that'll tell you that you have a single deletion on in that region. Similarly, you can see things on the array that may be even smaller than FISH, but you can have a duplication where you can actually see a subjective increase in signal on the FISH that then can be confirmed on array and actually give you a better size picture for how big that is than you would see on FISH alone. Okay. So the more complicated testing, that people are less familiar with how it actually works, but we like to use it a lot, is next-generation sequencing. So that encompasses both multi-gene panel testing and exome sequencing, and even now coming into genome sequencing. And the way that works is we take whole genomic DNA, cut it up into little pieces, and prepare a library of DNA, and then you make copies of those pieces of DNA indiscriminately to enrich every one of the targets that you're interested in. It goes through a very large, it goes on a flow cell and goes through a very large sequencing machine, and a lot of this is very much black box technology. It goes on the chip, it goes to the sequencer, the results come out on the computer, and then once the computer analysis occurs, a human actually goes through and evaluates it. So this is just another image of how that works. Genomic DNA is here. You sort of tear it up and make it into fragments and make copies of those fragments. You stick it to probes. The probes go on to the flow cell. The flow cell goes into the sequencer, and then you get just strings of sequence data. The computer programs that we use then map and align those various fragments of DNA sequence, and then they allow us to, once they're aligned, make calls about variants. When we look at fetuses and children with whole exomes or genome sequencing, there are 4 ways we can do this. One is we can identify individuals in different families who have overlapping phenotypes, and when we see changes in the same gene over and over again with a phenotype that overlaps, that's frequently a clue that this is a gene that's causing disease. We can use an extended family pedigree and test multiple affected and unaffected individuals to try to identify if the genes that we think are causing disease are actually involved, based on using reference material from each of these individuals to compare back to the original sequence data of the proband in question. Most frequently, we use a trio setup, so dad, mom, and baby or fetus, where the fetus is the primary sample, and then we use mom and dad for reference samples. That allows us to look for autosomal recessive inheritance patterns, as well as de novo or new in the baby or fetus patterns of inheritance. And then finally, we start usually in genetics by finding the individuals on the most severe side of the spectrum of this disorder, and those people are picked up first. And as we go over time, we find people with milder phenotypes who also may have milder mutations in the genes, and so that helps us identify the spectrum of disease in these individuals, and that's one of the ways we can also interpret these data. So further into this conversation, the role of medical geneticist and the genetic counselor is essential in combination here for counseling and result interpretation. I couldn't do it without my genetic counseling colleagues. We work as a team. Next generation sequencing panels are frequently what we use when pregnancies are continuing, but a diagnosis is highly likely, to assist with both delivery planning and prognostication for outcome. Typically, if termination of pregnancy is under consideration, or there's a perinatal lethal case where we're very worried about getting a diagnosis, we're more likely to pursue whole exome sequencing, because it'll be able to predict better recurrence risk, and we're more likely to find an answer the first time around. And it'll help give that diagnostic explanation to families as they plan their future pregnancies. The most important thing about this testing is there are 3 possible outcomes, and these are based on the ACMG criteria. So the main outcomes are we can get negative, meaning we get no answer, that we don't find an answer to why the baby or the fetus has this issue. Positive meaning we find an answer, and which is frequently for families not positive, because we end up having to tell them some very bad news, and then we have to help them figure out how to cope around that as they build their family. And oftentimes the most frustrating and difficult for both ourselves and for families is the variant of uncertain significance. These are reported out frequently. It's usually based on the fact that this particular change has never been reported in affected individuals, or has been seen intermittently in reportedly healthy individuals in the databases, or the in silico or computer-based prediction models for disease pathogenicity of a change are out of whack with each other, and so it creates confusion in how to interpret it. And so the really important role for me here are in all of these, but specifically where we are faced with this variant of unknown clinical significance. It's trickiest in fetal medicine because it's oftentimes harder for families to get testing when we have a VUS for future pregnancies, because most labs don't want to do that and base a pregnancy decision in the future off of an unknown or uncertain significant variant. So it matters a lot in this case, and that's why it's important that genetic counseling occurs before and after the results are returned. So finally, medical geneticists like myself can assist families with understanding fetal findings and possible diagnoses and outcomes in complex fetal consultations. Fetuses with confirmed genetic diagnoses, those families with relevant histories at risk for recurrence, and fetuses with significant congenital anomalies are appropriate reasons to refer for consultation with genetics. And advanced genetic testing techniques are complex, and interpretation of those results can be tricky, so we are here to help with those. And with that, I'm happy to take questions. Hope I didn't go too fast.
Any questions?
Can I appropriate the term VUS?
You may.
MRI report?
You may. You guys have
VUS in the MRI.
You have that. It's the MRI hedge. It's the cannot exclude.
Oh, clinical significance.
Correlation is recommended.
I like VUS.
You may have the VUS. I will give it to you. I can.
Okay.
All right.
Thank you.
Thank you. I don't know what happened.
Any questions on the outside? No? Crystal clear.
got there. Everybody fell asleep after lunch.
Thank you very much.
Thank
Jamie.
you.
Thanks a lot.
Sorry.
Yeah,
I've never done this before.
Okay.
I know not what I do. I just wing it. Boo, say.
I have a question. When we talk about major versus minor, I guess that could be subject to interpretation.
Yeah.
What do you? Is there any kind of guideline that you use?
Yeah.
Whether an anomaly is major or minor?
So if we're seeing